Hello everyone, I'm Dr. Mohit Kapoor. I'm a first year radiologist JR at AIIMS Bibinagar, Hyderabad, and today I will discuss an interesting case with you. So, this was a case of a 27-year-old female presenting for her first antenatal scan at 26 weeks, and she came with complaints of pervaginal bleeding for last 2 days. She was referred to us by obstetric and gynecology department with complaints of unable to find fetal heart rate. So, as we began our scan, the first thing we could see was the uterus was markedly enlarged in its size. Further, as we started with the scan, we could see there was this heterogeneous mass within the uterus, in the endometrial cavity within the uterus. And as we progressed with our scan, we could see this heterogeneously echogenic mass contains multiple cystic lesions of variable size within it. So we could see the uterus was markedly enlarged in size. There was this heterogeneously echogenic mass containing multiple cystic lesions of variable size within it. This is called as a grape-like cluster appearance or a cluster of grape appearance. And these all findings were very characteristic of a molar pregnancy. Further, if we asked for beta HCG of this patient, and there were also abnormally elevated in this case. So these all findings were suggestive of complete molar pregnancy. Further, we also put on color Doppler, and what we could see was there was some vascularity seen in the septal component of this patient. However, we could not find any fetal pole or fetal cardiac activity in this case. And we could also see some cysts in the ovary also, and these cysts were thicker lutein cysts in this patient. And these thicker lutein cysts are commonly seen in complete molar pregnancy, and they are associated with increase in level of beta HCG. The thing with these cysts are they can also be markedly increase in size, and they can undergo hemorrhage or torsion, and that can be a cause for pelvic pain in this set of patients. So given all this finding, the impression which we gave was a complete molar pregnancy. So starting with the literature review of this case. So this set of the case, that is molar pregnancy, comes under a broad category of gestational trophoblastic diseases. So gestational trophoblastic disease, as its name tells, it is a spectrum of diseases arising from the placental villus trophoblast. And it includes a benign category called as hydatiform mole or H mole, which could be partial or complete, or it could include malignant category of GTN or gestational trophoblastic neoplasia, which could be invasive mole, choriocarcinoma, or placental site trophoblastic tumor. In this discussion, we are mainly going to see H mole or hydatiform mole. So H mole or hydatiform mole, it is the most common and benign form of gestational trophoblastic disease, and it most commonly present as vaginal bleeding in females. However, if the female complains of passage of grape-like vesicles through the vagina, this is very characteristic of complete molar pregnancy. Further, like we told, the serum beta HCG level will also be abnormally elevated in this patient. Usually it will be elevated more than 1 lakh milliliter units per ml. Further, we could also see multiple bilaterally enlarged thicker lutein cysts in this patient also. And like I told you, these cysts can undergo hemorrhage or torsion and can be a common cause for pelvic pain in this set of patients. Further, the management of H mole or hydatiform mole is by uterine evacuation, which is adequate most of this patient as this is a benign category. However, the ACOG guidelines recommend that we should go for follow-up testing of beta HCG level for 6 months even after the level becomes undetectable. Like I told you, H mole can be characterized into a mole, complete mole or a partial mole depending on cytogenetic and pathological features. So in this example, we can see this is a normal conception. We have a normal ovum, we have a normal sperm. They fuse, form a 23 set of chromosome. They form a 46 set of zygote. So this zygote has 2 set of genes. One is from paternal, one is from maternal, and the fetus will be viable, which form from this zygote. However, what happens in complete mole is the ovum is empty. The maternal component goes out, so we have an empty ovum. In this empty ovum, we could have one of 2 things. First, we could have a single sperm which will go inside. It will duplicate, and this will form a 46 set of chromosome zygote. Or second thing what we can happen is we could this empty ovum could undergo fusion with 2 set of sperm, that is dispermy. So here we will also have two set of chromosomes, two set of genes, but this both set will be of paternal. There will be no paternal genes in this patient. As there are no maternal genes in this patient, there will be no fetus in this patient. Coming to the third criteria, that is partial mole. What happens there is we have a normal zygote with normal egg, and it is fused by two set of sperms, and this will cause a zygote having three set of chromosomes, and this three set of genes will have one maternal and two paternal component. So fetus which formed here will be non-viable. So coming to differentiating of partial mole and complete mole, like I told you, complete mole will have two set of paternal genes. So we will have 46 sets of chromosome. Whereas in partial mole, there will be one maternal and two paternal. So we will have 69 set of 69 chromosomes. That is three set of genes. So pathology wise, fetus will be seen in partial mole, not in complete mole, as complete mole will have two set of paternal genes, not maternal, so there will not be any fetus seen. Same amnion fetal RBCs will be seen in partial mole, not in complete mole. Now coming to villus edema and trophoblastic proliferation, this is commonly seen, this is completely seen in complete mole and partially seen in partial mole. That is, it will diffuse. Villus edema and trophoblastic proliferation will be diffuse in complete mole, and it will be focal or partial in partial mole. Clinical presentation: complete mole, like we saw in this case, will have a clear-cut appearance of a molar pregnancy, whereas partial mole will appear like a misabortion case. Uterus will, in complete mole, uterus size will be larger for gestation age and smaller in partial mole. Thecal uterine cysts are more commonly seen in complete mole. Medical complications are also more common in complete mole. These partial or complete mole are usually benign, but they can undergo malignant sequelae, and that risk of them is more in complete mole and less in partial mole. Now coming to understanding of this, so complete mole, like we saw, we will have enlarged uterus with a central heterogeneous echogenic mass that has multiple cystic spaces within it, and this is called as a bunch of grape appearance, which we saw in this case. But this finding are more common in second trimester. In first trimester, these appearances are variable. That is, we could even find some solid mass or some fluid collection also. So it's not very clear cut like we see in second trimester. It's very variable in first trimester. Coming to partial moles, in partial mole the placenta is enlarged and it contains multiple anechoic cysts, and we will also have fetus which will be non-viable, or if it's viable then it will be having multiple congenital abnormalities. So like if you can see in this example, this were taken from Rumac. So in this case we could see this was the uterus which was remarkably enlarged, and within this uterus we could see this heterogeneous mass containing multiple cystic lesions of variable size. This was clear-cut case of molar pregnancy. Then coming to a second set of images, in this one we could see there was an intrauterine gestation sac, and in this sac there was one fetal pole seen within it, and this fetal pole was smaller for gestation age. Further, we could see placenta having multiple small thecal uterine cysts, placenta having multiple cystic lesion within it, and this was clear-cut case of a partial mole. So we could see multiple cystic lesion in the placenta and an embryo which was smaller for gestation age. Last, I also put one case study which I saw in the net while studying for this case, and in this we could see this was a placenta having multiple cystic lesion within it, suggesting that it's a partial mole, and we could also see fetus within it, and the fetus was supposedly viable at that time. So this was also a case of partial mole. So the reference which I used in this lecture was from Carol M. Rumac. Thank you very much.